All right, it's 4 o'clock. We're going to get started. Thanks so much for coming along, everyone. My name is Randy D'Amico. This is Tumor Talk. It's a collaborative effort between the Journal of Neuro-Oncology and Lenox Hill Neurosurgery, where we highlight recent publications in the journal and we talk about kind of the rationale for the study, the results, and obviously the clinical relevance of the study. We're pleased today to have Ben Ellingson with us and his team. And so without further ado, Ben, if you want to introduce yourself, introduce your team, and we'll dive right in.
Sure. My name is Ben Ellingson. I'm a professor of radiology and director of MRI research at UCLA. And I'm here with my colleagues who helped with this manuscript. And I guess we'll kind of go around. Noriko, maybe.
I'm Noriko Salamon. I'm a neuroradiologist at UCLA.
Satoko?
Thank you so much for inviting us for Tumor Talk. I'm honored to be part of this webinar today. I worked as a neurosurgeon clinically in Japan, and I worked under Dr. Edison and Dr. Salmon from 2019 to 2021. And in the middle of this research project, actually COVID pandemic got started everywhere in the world. So we had to work in that situation remotely and separated for long. So I was very happy in that great team work in Dr. Edison and Dr. Salmon's place, and very happy to get this paper finally published in your journal.
Ricky?
Hi, everyone. My name is Ricky. I'm a resident in radiation oncology, and I had a great privilege to work with Dr. Ellingson and the team on this project.
Thanks. Nick?
Hi, everyone. My name is Nick. I'm a current MD PhD student in Dr. Ellingson's lab, and I'm honored to be here with all my mentors.
Last but not least, Takafumi?
This is Akihumi Hagiwara. I'm a neuroradiologist. I'm honored to be part of this project. Thank you.
All right, sounds good. So now let me share my screen, and we'll just briefly go through the paper. Can you guys see it okay?
Yeah, it looks perfect.
Great. So this paper, I have to give a lot of credit to Satoko and Ricky, who really spearheaded this, as well as the collaborators in radiation oncology, Tanya, and in radiology, Noriko, for putting together and kind of, actually getting this paper the light of day. So the title of the talk is Relapse Patterns in Radiation Dose Exposure in IDH Wild-Type Glioblastoma at First Radiographic Recurrence Following Chemoradiation. And so a little bit of background first. So as we all know, the standard of care for IDH wild-type glioblastoma really consists of maximum safe resection, followed by postoperative radiation with concurrent temozolomide, followed by adjuvant temozolomide. And this may be done with or without tumor treating fields, again, depending on what institution you belong to. However, recurrence rates in GBM are over 90%, and there remains no real standard of care for recurrent GBM. So previous studies have really done an excellent job showing that dose escalation at standard fractionations up to 60 gray improves survival. And for the most part, tumor recurrence occurs locally within the original, 95% isodose zone. And so what we wanted to do is kind of bring a more contemporary and detailed analysis to really quantify the incidence and the degree of local recurrence to add on this kind of wealth of previous information, as well as show how these characteristics correspond with patterns of progression. So at the time of recurrence, does the tumor look different than it does at diagnosis? Oh, geez. So in the current study, we explored the dose distribution within the contrast enhancing tumor, as well as the lesion morphological metrics, so what the shape characteristics, et cetera, at baseline and the time of radiographic recurrence. Based on previous observations and based on the literature, we hypothesized that in the vast majority of recurrent tumors would recur locally within therapeutic radiation doses, and that tumor recurrence at long progression-free survivals may be more solid and nodular, and something to keep in mind as we move forward. So in the current study, we looked at 48 patients that were in a well-defined cohort with histologically confirmed IDH wild-type glioblastoma, who underwent standard of care postoperative IMRT with concomitant and adjuvant temozolomide again, according to the Stoop protocol between 2011 and 2019. The standard RANO criteria was used to determine progression before or after 12 weeks following radiation therapy. If progression occurred within the first 12 weeks after completion of IMRT, we used a modified RANO criteria that confirmed progression in order to make sure that this wasn't sort of a pseudo-progression type event. And we, co-registered all of the images together, as well as the dose characteristics for each patient at the time of radiation planning, as well as the time of recurrence, to see what happened within the radiation fields. So one of the measures that we looked at first was really the distance of recurrence. And so to quantify this, it's kind of a crude measure. We looked at the center of mass of the enhancing tumor at the baseline prior to treatment and at the time of recurrence. So here you see a representative patient. Here you see the blue tumor or the blue outline and or volume of interest is the tumor at the radiation planning prior to radiation. The dark dot you see here is the centroid location. And then the red area or volume of interest here is what the tumor looked like at recurrence. And the dark red spot kind of embedded in here is also again, the center of mass at recurrence. We also quantified two specific shape features, the first being the sphericity of the tumor. And this is really how close the lesion is to a perfect sphere shape. It's really the ratio of the volume to the surface area, what we would expect out of the surface area of a sphere. And so as the tumor or the volume of interest becomes more spherical in shape, this number approaches 1. We also quantified the solidarity of the tumor, and this is really, kind of corresponds with the density of the enhancing tumor. And it's defined as the volume of the enhancing tumor divided by what's known as the convex volume, which is the volume defined by a convex hull around the object. The idea is that the more solid, nodular, and kind of well-defined this is, it approaches 1, as opposed to if it's a more diffuse, sort of irregularly shaped tumor with a lot of holes in it, that would be a lower sort of density or solidarity of the tumor. So we specifically hypothesized, based again on the wealth of previous studies, that tumors will recur near the site of the original tumor. And so we theorized that the tumor centroid at recurrence would be less than 5 millimeters from the centroid prior to chemoradiation treatment. We also theorized that tumor recurrence will really occur within therapeutic doses, so more than 60 gray, in a large proportion of patients, again, consistent with the previous literature. We also theorized that tumors that had a longer progression-free survival, so took a long time for the tumor to recur, will recur more distal from the original site, so a further from the original tumor bed, and potentially be more spherical or more sort of nodular in shape. We theorized that there might be a correlation between progression-free survival and distance of the centroid. This could be dependent on MGMT status, which may prolong progression-free survival or may have different characteristics at recurrence. And then we also theorized that there might be some dependence on progression-free survival on the specific sphericity and solidity at the time of recurrence. So these are some of the results, again, published within the paper, looking at the patterns of recurrence. Here on the left, here in panels A and B, you see the original and at recurrence where the tumor location, where the centroid locations were. In A, the size of the dots correspond with the volume of the tumor, so you can kind of get a sense of whether or not large tumors, moved shorter distances, etc. And then in panel B here, you see the centroid location at planning and at recurrence for all of the patients included in the study. So on average, the centroid of the enhancing tumor seemed to shift or change an average of about 11.3 millimeters, or about a centimeter at recurrence, which was significantly higher or longer than what we theorized as being 5 millimeters. So it was a lot longer than we expected. And we didn't, at first glance, we didn't really see a correlation between progression-free survival and centroid location. But as we broke it down into patients that were MGMT methylated promoter methylated or unmethylated, we did notice that there was a significant positive correlation between the centroid differences, so how much that centroid moved between radiation planning and recurrence, and progression-free survival, but specifically within the MGMT methylated group and not within the unmethylated group. So in other words, in MGMT methylated patients, the longer the progression-free survival, the longer or the further away we saw recurrence from the original tumor bed. We then used Cox multivariable regression to see whether or not these were kind of independent factors, and it confirmed that continuous measures of centroid distance was associated with progression-free survival, while MGMT status was not significantly associated with PFS. So accounting for MGMT status, the centroid distance was a significant prognostic factor for progression-free survival. Again, confirming that the longer it takes to progress, the further we are from the original tumor site. Additionally, we didn't note any difference in sphericity when looking at the baseline tumor versus tumors at recurrence. However, if we broke patients or we stratified patients based on whether or not they progressed within 12 weeks of finishing IMRT or after 12 weeks finishing IMRT, we did notice that those patients that progressed after 12 weeks of finishing IMRT had significantly more spherical shaped tumors than those that progressed early on. In terms of solidity, we saw a significant increase in the solidity of the tumor at the time of recurrence with respect to baseline, and this was no different between whether or not the patients progressed before or after 12 weeks of finishing radiation treatment. It's important to note that both at baseline and at recurrence, there was a significant association between how spherical and how solid the tumors were at both time points as well. So even though we saw this relationship on the previous slides, they do seem to be interrelated in terms of how solid or dense the tumor is and how spherical or sort of nodular shaped it is. In looking at the effects of radiation dose, we didn't notice any differences in the average IMRT dose between the baseline time point, so the amount of enhancing tumor that was covered by those therapeutic doses, and at the time of recurrence, where that enhancing tumor was and what the original dose fields were or radiation fields were. So baseline enhancing tumor volume interest and the tumor volume interest at recurrence on average had more than 60 gray kind of exposure, and there really was no difference in the distribution of radiation dose at those two time points. There also was no difference between the baseline enhancing volume of interest before and after 12 weeks post IMRT. So if patients progressed early or late, that didn't seem to make a difference in terms of whether or not the bulk tumor received a therapeutic dose. Similarly, recurrence of enhancing volume of interest before and after 12 weeks post IMRT at recurrence also didn't show any difference. If we look at all the individual patients here, we see that on these box and whisker plots at the time of the radiation planning, the bulk of the tumor in all circumstances was above 60 gray. But you can see that these are, voxel-wise dose distributions. We see that in some patients, there were enhancing components of the tumor that didn't receive more than 60 gray. But again, it was a minority of the tumor and in a minority of patients. If we look at B and C here, these are if we take the dose distribution for every individual patient, throw them all together into a single histogram. And again, you'll note here that this is in log of number of voxels, so it's a little bit different scale here. We see that the vast majority of the tumors in the individual patients did receive therapeutic levels of radiation, and only a few kind of stray voxels again received sort of some therapeutic doses. At the time of recurrence, we see that on average, things seem to be about the same in terms of the enhancing tumor at recurrence did seem to be above this 60 gray threshold, but there were individual patients, for example, patient number 23 here, where the bulk of the tumor now was actually recurred, outside the original high dose lines here. But on average, you'll see that most of the patients recurred within therapeutic levels of radiation. Again, if we look at the individual patient histograms, we see that there are some patients that seem to be sort of outliers here, where at the time of recurrence, the enhancing tumor was, received, was outside the original, 60 gray isodose lines and things like that. So in conclusion, the results of our study showed and kind of confirmed that most glioblastomas recur locally and within therapeutic doses of radiation. So the average radiation dose within the enhancing tumor at baseline and recurrence was over 60 gray. So they didn't seem to be failing sort of outside that radiation field. We also noticed that tumors that had a longer progression-free survival seemed to recur further from the original tumor location. And this seemed to be particularly in MGMT methylated patients. And at the time of recurrence, the longer the progression-free survival, the more solid and nodular the tumors ended up being. So in particular, we saw a positive correlation between the change in centroid location and progression-free survival in methylated patients, even when accounting for clinical factors. And again, lesion solidity was higher at recurrence when compared to baseline. And in patients that progressed more than 12 weeks after radiation, they seem to be more spherical or sort of nodular in shape. So with that, I want to thank all my funding sources, thank the lab who did all this work and did a great job putting it all together. And again, thank you guys for your time.
Thanks so much. I really want to, first of all, extend a thank you for choosing the Journal of Neuro-Oncology to publish this in. Obviously a complicated study requiring kind of the efforts of everyone involved, and you guys did a great job. I think it's an easy read, and it makes a lot of sense. Like any good research, it begs a lot of questions, right? And I have one easy question, one harder question. I guess my easier question is what I'll start with, and I'm curious what you guys think. Is there anything in the data that you didn't mention, or if there's anything from the conclusions we can draw that argues that this paper is really an argument for a supramaximal resection? We're getting recurrence within the treatment field. We know that there's going to be failure within a therapeutic dose, but we're seeing better progression-free survival with more distant recurrences. With gliomas, we know we're taking out portions of brain, and so that your closest recurrence can be at your margin, basically, of your resection. And so should we be taking out more tumor when safe or when apparent?
Yeah, I think some recent data from the sort of RANO-RESECT group kind of does confirm that. So those patients that were unable to undergo sort of supra total resection, so beyond even into the sort of non-enhancing T2 hyperintense areas, those patients seem to have a survival advantage as well. So I do think that there's an argument for either taking more tumor, or the other thing that we didn't look at was the effects of radiation into that non-enhancing tumor bed. How far did it extend? How much of the flare area, which we know can contain a mixture, but how much of that was covered? That the practices for radiation treatment are slightly different in Europe versus Australia versus the US in terms of where they boost those margins and things like that. So I definitely think that there's room to explore some of these things in a little bit more detail.
Yeah, definitely. And I guess then, the other argument or the other question is, why is this happening, right? We're delivering a therapeutic dose. So why is tumor coming back in those regions preferentially? And that's, I think, a tougher question to answer. I know, when I think about my questions, I think about the answer that I would give. I don't have one. So.
Yeah, I mean, the one thing that I think is a glaringly missing from this study is at the time of radiographic recurrence, do we know that this is truly sort of progressing or growing tumor and it's not, confounded by treatment effects, and to what degree it's confounded by that? We did notice that some of these patients did have, significant regression of their tumor for a period of time. So as the tumor started to regrow, that's when we call progression, but it may be smaller than what it first started with at the time of progression. And so, really understanding the limitations on what we're calling progression and the clinical implications of that, I think, are going to be important as well.
Yeah, and I think obviously the other difficulty here is it's a heterogeneous group of individuals, right? Tumors in different locations where you guys, I don't know if you commented on the extent of resection in a lot of these cases, but we don't know that necessarily. And we don't know what your radiation limitations were as well in terms of delivering therapy. Are you guys, do you guys do anything like network sparing or hippocampal sparing in your treatment paradigms?
That'd be a question for Ricky.
Not for GPMs, we don't.
Yeah.
Of course, for brain metastases, we would do hippocampal sparing. Even for brain metastases, we've not done network sparing. I know there's some recent works from UC San Diego and other groups that have done white matter and particular network sparing, but we've not done this routinely for GBM just because the tumor aggressiveness.
Yeah. And I guess the next study is the reoperation, right? And finding out what this enhancement is that comes back.
Yep.
Yeah. Well, guys, again, a fantastic study. I really appreciate y'all being here. We'll cut it a little bit short unless anyone in the audience wants to ask any additional questions. I think, a difficult study, and I guess, to close it off, how do you interpret this as a clinician now, seeing your results, and, how do we use this to make our care of GBM patients better, or do we use it to, further our understanding of what our treatments are doing?
I think one thing that we're constantly kind of asked in tumor board and things is whether or not, we look at the time from finishing radiation and the tumor kind of gross characteristics and trying to determine whether or not we think that this is treatment related or recurrence, or if it's something to worry about. And I think, trying to put some parameters on how the tumor looks and the time from finishing radiation and how that might evolve, I think will be important. So, again, if it's far out from radiation, the tumor looks nodular, it looks very solid, then you probably are pretty confident that this is probably recurrent tumor, particularly an MGMT methylated patient. So hopefully this fits in with the larger kind of scheme of what people are trying to put together, and maybe with the help of advanced imaging and things, it can kind of help paint the right picture. So
Absolutely. Well, congratulations to y'all. I know that this was a cover article, right? This made the cover of the journal. You guys, all your efforts are obviously been rewarded. And so thanks for participating in Tumor Talk. We look forward to having you back with the next study and some others. So anytime.
Sounds great. Thank you. Thanks for the invitation.
All right. Have a great day, everyone. Thanks a lot.
Thank you.
Thank you.
Thank you.